the Veteran Virtual Ride Cohort program. Every year, the VA manages billions of dollars in preventable chronic conditions, cardiovascular disease, diabetes, depression, and isolation-driven health decline. Emergency room utilization remains high among veterans with unmanaged chronic disease. But what if we could intervene earlier, affordably, measurably, and at scale? Hospitals across the country are beginning to prescribe cycling as preventive medicine. At Boston Medical Center, physicians prescribe access to the Blue Bike system, integrating physical activity directly into patients' daily lives. This model is supported by insurers like Blue Cross Blue Shield of Massachusetts, which fund and expand the cycling infrastructure to improve access and reduce long-term healthcare costs. Together, this creates a new model of care, where mobility itself becomes medicine. The question is simple. Can the VA implement a structured cycling-based intervention to reduce long-term costs and improve veteran outcomes? We believe the answer is yes. Veterans experience higher rates of cardiovascular disease, type 2 diabetes, obesity, PTSD, depression, and social isolation. These conditions are interconnected. They drive ER visits. They increase hospital admissions. They raise long-term pharmaceutical dependency.
From a clinical standpoint, inactivity is a compounding factor. When cardiovascular decline intersects with depression and isolation, risk multiplies. Yet most interventions remain reactive. After crisis, after deterioration, after ER presentation. We need preventive infrastructure.
The Veteran Virtual Ride Cohort program is a structured, measurable cycling initiative using smart trainers, heart rate monitoring, virtual ride platforms, cohort-based group rides, and integration with OT, PT, and behavioral health. This is not recreational cycling. This is structured preventive medicine.
Participants ride within safe, monitored heart rate zones. Progression is gradual. Engagement is group-based. Physiologically, we see improvements in VO2 capacity, blood pressure, glycemic control, and weight management. Psychologically, structured group rides reduce isolation and improve mood regulation. Veterans don't log in for therapy. They log in for a mission, but what they receive is clinical benefit.
Let's discuss cost. The average ER visit ranges between $1,200 and $3,000. Hospital admissions can exceed $10,000. A complete smart trainer setup, trainer, heart rate monitor, mat, and platform access often costs less than a single ER visit. If this program prevents one ER visit per participant annually, or delays diabetic progression, or reduces cardiovascular events, the return on investment becomes immediate. Preventive infrastructure costs less than crisis management.
Regular aerobic exercise is strongly correlated with reductions in depressive symptoms and anxiety markers. Group structure adds accountability. Peer engagement builds protective factors against isolation. For veterans managing PTSD or depression, physical engagement combined with structured peer interaction creates dual therapeutic effect.
This is dignity-centered intervention. No stigma, no labeling, no mandatory therapy. We propose a 12-week pilot cohort of 6 to 10 veterans, structured as a peer-led program with clinical oversight from rehabilitation and behavioral health providers. This model combines veteran-to-veteran engagement with professional supervision to ensure both safety and measurable outcomes. We will track both physical and mental health improvements using validated clinical metrics. From a behavioral health standpoint, we will quantify outcomes using standardized tools, including reductions in depressive symptoms using the PHQ-9 reductions in anxiety, using the GAD-7 improvements in perceived stress levels, increased social connectedness, and reduction in isolation scores. We will also monitor program adherence and participation rates, session attendance and cohort engagement, self-reported mood and energy levels.
These metrics allow us to evaluate not just participation, but clinically meaningful improvement. Combined with tracking reductions in emergency room utilization and improvements in cardiovascular health, this pilot provides a complete picture of both health impact and cost reduction potential. Physiologically, we see improvements in VO2 capacity, blood pressure, glycemic control, weight management. Psychologically, Structured group rides reduce isolation and improve mood regulation. Veterans don't log in for therapy, they log in for a mission. But what they receive is clinical benefit.
For veterans facing financial barriers, we propose loaner equipment programs, facility-based cycling rooms, sponsored access partnerships, software licensing through VA infrastructure. No veteran should be excluded due to cost. Cycling is not recreation in this model. It is preventive cardiology. It is behavioral health support. It is community restoration. It is cost containment. The VA has an opportunity to lead, not react. Lead. Let's pilot it, measure it, and build a model that reduces ER visits while restoring veteran health. Thank you.